Hi, we're back. 3:54. We made it. Before we go to our last panel, where we're going to kind of see the culmination of the work and the talk that we've had today come together in a panel about our health data utility, I really want to take one more minute to thank you for being here with us. Thank you for leaning in and for engaging. Thank you for spending your time, which is your most precious commodity. And I really, really want to give another shout out to our sponsors, Blue Cross Blue Shield of Michigan, Cloudticity, Augusto, Diameter Health, Health Focus, HIMSS Michigan Chapter, MAHP, eHealth Technologies, and Fitzmaurice Garden. Thank you so much. And now I'm turning over to Tim.
Thanks, Joanne. Hey, what a day, huh?
Oh my God.
We've just had so much wow kind of
There's
stuff.
been a lot.
I mean, just one after another. So really exciting. There's some wonderful stuff going on. One of the things that we want to do is we want to wrap up the day with a panel that's a little bit, I don't know, let's just call it the future of HIE. And that is got a handful of folks that are going to be joining me here on stage. And if I can get excellent, they just magically appeared. I love how this works. So if we can, perfect. All right. So basically, there's going to be three of us. We've got Angie Bass from Velatura HIE Corporation. And Angie has been in this business for a while. She's sort of started HIE, ran HIEs, been on the board of our association, is now on the board of our new association that just got sort of created and merged with some other folks. She's been on the front lines of sort of working with the public sector, with the state, as well as really trying to bridge multi-stakeholder data sharing kinds of activities together in a production way. And now she leads what we hope will eventually become the largest HIE in the country. And then Brandon, I didn't practice saying your last name properly. Would you say it properly for me, just so I can make sure it's enunciated?
Sure, Tim. I'll give it a shot. It's Nicewinder.
Nicewinder. All right. So Brandon, with CRISP, many people have heard me say that if there's another HIE in the country that I think you should look at and model, in addition to Mayan, it's CRISP. They've been at this a long time, and they're certainly one of the leading HIEs in the nation, and the space I look to for what is the future direction need to look like. So I'm really pleased that Brandon Nicewinder can join us. Brandon is the VP and Chief Strategy Officer at CRISP. He also plays a strong role in the sort of privacy and security front, which we've heard a little bit about some of that in sort of the citizen space with Shreya and company. He also has a long career in this space. He was a senior director of health information exchange and population health for St. Luke's University Hospital Network, where he had similar functions in terms of implementation and strategy and management of a lot of the community-wide network and information exchange. Prior to St. Luke's, Brandon served as the director for health information technology at Erickson Retirement Communities, where he was responsible for the operations and management of a $15 million healthcare technology infrastructure, which included ambulatory EMR, practice management, and financial systems. And then there's myself. I've been in this a little bit as well. All three of us have sort of scars upon scars of being in the trenches. We have worked hard to sort of solve real world problems, whether it's in the community, whether it's in a hospital, whether it's a payer, whether it's with the public sector. And we're going to spend our remaining time here really going and talking a little bit about health data utilities. And so if you could transition us to the next stage, or next slide, please. So what is a health data utility, and where did it come from? And one of the things that became abundantly clear to the country at large was that you need an infrastructure. You need the things that HIEs have been articulating for over a decade now. You need that capability in order to respond to the kind of initiative that COVID represented. And one of the things we learned is that the EHR is not, surprisingly, the center of the universe. It's actually an important ingredient, but it is actually not the entire meal. And out of that discussion arose a conversation about health data utilities. And this is an emerging national model that really looks at a network of coordinated state-based infrastructures or health data utilities that really solve for a variety of local, state, and regional needs, that acts as this shared infrastructure to help folks get data in real time that is sort of persistent, reliable, and scalable, and a really reusable shared infrastructure for all of the actors in the healthcare ecosystem. And I'm wondering, Brandon, one of your colleagues is sort of part and parcel to the actual coining of the phrase of a health data utility. Were you present when they sort of did that HIMSS presentation, or were you somewhere else on that day?
I was present when they did that HIMSS event, Tim.
And who was that who basically coined this phrase that's become sort of a national buzzword?
Well, I think it might have been Mr. David Horrocks, as he was finishing up some of his doctoral studies at Hopkins and leading a lot of the health information exchange use cases over the past 12 years, and tried to envision what we would become over the next 5 to 10 years. And that's he kind of coined that phrase to make it, instead of saying something like HIE 2.0, he went a completely different route and decided health data utility might be a better way to think about things.
And just to be sort of give full credit, I think on that actual HIMSS presentation that we're giving, we're saying was where that phrase got coined. I think John Kansky was also a part of that presentation, and John is from another very famous HIE in the nation, out of Indiana, for IHI, for those of you who are not familiar with that. So basically we had two of the greats in our industry kind of come forward and basically say, hey, this is what the future looks like. And that future is a health data utility. And so what we'd like to do is really spend some of our time between Angie and Brandon and myself really talking a little bit about this particular space. And so let me go ahead and kick this off and say, hey, Brandon, what does a health data utility mean to you?
Well, I think, working with David, and as him and John work together on kind of setting the initial stage for the next phase of HIE, I think the most important thing to think about a health data utility is there's a lot of technical mumbo jumbo, and we got to do a lot of connectivity, and there's a lot of pieces. But at its core, I think a health data utility is an organization that once it's connected and has access to data, that data gets combined so it can become more useful, more relevant, specifically at the point of care, in care coordination use cases, et cetera, really to help with both public health needs as well as day-to-day treatment and care coordination activities amongst the healthcare provider. So again, a health data utility combines data to enhance data at its core.
Similar kind of question, but Angie, where do you see sort of the national agenda for health data utilities heading?
Heading towards true insights, true intelligence, using data to inform policymaking, to inform reimbursement models to give us all of the intelligence we need to actually transform the delivery of healthcare and be impactful at a societal level, at a community level, and not just at a hospital or a clinic. To really think about the patient in a comprehensive way, finally, because we are the collection of all data sets, not just a clinical or not just a registry or not just claims data. It's finally breaking down the silos so that we can be more meaningful and useful than we already are.
One of the things that David articulated that I think tells a really good story is the vision that was cast for health data utilities was a network of them operating together across the country to really ensure a public health and a population health infrastructure that could be relied on, not just in crisis, but in everyday kind of healthcare. What do either one of you think about the feasibility of that kind of national infrastructure emerging? Is that like a long way off? Is that a decade off? Where do you think we are in that journey for that becoming a reality?
Angie, I'm going to jump in first on this one, then maybe you can go and give your rebuttal. Maybe, hopefully, it's aligned. I believe that a nationwide one-stop shop network will take more time to get to. I think what you will see is multi-region shared infrastructures with underlying connectivity as a shared service or a shared technology stack, where states and regions are able to set their priorities based on connectivity models that are managed securely and with the appropriate data use agreements. I don't think everybody's going to just jump in and have the same exact policy on how to use data right away, but I do believe that there's an opportunity for, I think, an aggregate shared service layer that supports public health and health data utilities. I think that you'll see organizations teaming up together to provide larger network infrastructures that provide more access to data. I would say you probably get 3 or 4 of those types of big organizations over the next couple of years. And then I think that even those 3 over time will maybe get to 1 or 2. But that's my thought on infrastructure. I definitely don't believe that, for instance, Michigan or Maryland would necessarily have the same priorities unless they're at a federal public health level. Angie?
Yeah, no, I am aligned for sure. I would say that to get down the path fastest, it's going to probably be more than 3 or 4 to get us started. And health data utilities are going to have lots of alignment with different states and priorities. And so having more to start, and then over time having fewer with partnerships and alignments and mergers and acquisitions, I think is a natural attrition. I think that the first step out of the gate is establishing health data utility into law at the federal level, and then putting in the infrastructure behind it, from a policy standpoint, regulatory standpoint, infrastructure and funding and all of that. And so that's going to take some time. But the beauty of the HIEs is that the ground infrastructure is already there. The technology and the interoperability and the data exchange methodologies for onboarding and implementation is already there. It's what we do every day. And so now we just need to finish building on top of that foundation to put in the different pieces to become the data utility model. So we're already a decade into this, as opposed to just starting from ground zero. If we were at ground zero, then it would take a lot longer. So now we have a decade of years of experience to know what we should have known, hope the lessons learned over the last 10 years, so we can do it faster, smarter, better going forward. And a lot of advancing interoperability models to be able to leverage. So I think we still have a path to get down, and it's going to take some time to put the infrastructure in place, but it's a much shorter path when we utilize the HIEs.
Okay. Hey, so I want to play a little game, and basically it's going to be thumbs up or thumbs down. So basically, we're going to say, so we know who's in an HIE, right? We know you have provider organizations, you have health plans, you typically have a little bit of public health. You have doctors' offices, emergency departments, et cetera. Okay. What I'd like to do for this little thumbs up, thumbs game, so thumbs up means yes, definitely in. Thumbs down, no, probably not. Is who's in an HDU or a health data utility? So I'm going to say what kind of organization it is, and you guys go, yes, they're in, or no, they're not. Okay. So are state agencies like corrections potentially in a health data utility or not? Okay, and I would do that too. Okay, so are our county jails in? Because they're a little different than state corrections. Okay, good. How about schools? Are schools in? Schools are in. Okay. How about like the juvenile justice program? Folks who worry about whether we incarcerate or find after-school programs and specialized services. Are they in? Got one down. Okay. Brandon, what? And I would have said they're in, but what makes you think they might not be in?
I think the reason I was a little provocative on that one to say no. I think that those are the types.
It's going to get boring if you didn't. So yeah,
right.
help. Yeah.
I think some of these are nuanced regional decisions at a government level. And I think that when you get into juvenile, I kind of focus on juvenile at that point, where, who has the right to access that data. I think it gets a little bit murky from state to state. So I think it can be. I think when you start talking about schools and things like FERPA and the way data gets shared, I think it's all about the state and state departments having clear data use agreements on how that data flows, what use cases are allowed. So I kind of did that on purpose to say it depends. And it takes work to engage those organizations in a way that, one, gets them the appropriate information that you already are allowed to share, but two, accessing their data to be able to share out for other use cases. So it gets a little nuanced. So hopefully I wasn't too provocative there too.
No, I think that's great, because I think as we go, well, what about county government and county services? What about city, large cities, and what about their services? And I think we go thumbs up, where really when we're talking about this shared integrated infrastructure, we still have details to work through, and we can reapply the lessons we've learned in HIEs. But HIEs are really good at public health and HIPAA, the HIPAA legislation and rules. Where there is still work to be done is as we go outside of HIPAA to things like FERPA, to consumer protection, to social determinants of health areas that may not be well sorted out yet. We absolutely have to be careful of having the healthcare lens kind of coming in and dominating. We want to reuse those lessons, but we're going to get some pushback on really finding and making sure we have scalable shared approaches as we really craft health data utilities that serve these other sectors in the way they want to be heard and served. What about sort of the foster care program and children's services? That's a particularly interesting area. Yes? Okay. What about sort of behavioral health and mental health and substance abuse?
Yes, but.
Yes, but. What's the but?
Well, I think the really important part is data privacy rights and how we implement that. And I've seen state to state, region to region, interpretations on things like 42 CFR Part 2 consent requirements. So I think that those are things you just work through. Again, it's just a nuanced answer again. All of these have so much detail underneath, but if you have a shared infrastructure that can align with multiple interpretations of things like consent and sharing data, I absolutely believe that they're in. And it's a green field, I think, in a clinical perspective to say, how does a health data utility really enable, better access to care for folks that are being, treated in the substance abuse or, something specific like that in those areas.
Yeah. Like the way that I explain it is a health data utility is a convener of data and all kinds of data to make it available, to make aggregated data available to healthcare stakeholders as applicable and as appropriate, taking in all of the nuance that, Brandon, you've just described, patient consent, HIPAA, for whatever the regulatory environment is, whatever the political environment is, whatever the reading the temperature in the room, whatever the dynamics might be. The good thing to know is that the HIEs can manage that. We manage consent today. We manage being the traffic cop of you can have it, but you can, but you can't type of thing. So those are things by nature of being an HIE that we're already good at and why we are best suited to evolve to and now become health data utilities.
One of the things that comes to mind, and I'll call it the David Horrocks, Jankowski definition of a health data utility, is they were pretty adamant, and I think, Brandon, your comments sort of reinforce that, in that health data utility really has a boundary condition to some degree of sort of a state or a county or a city kind of mindset, because those nuances need to have some sort of jurisdictional boundary. Do you feel that that's pretty valid? Not that you can't work out these interjurisdictional agreements, but do you think there's some sensitivity that has to be pretty concretely that, get it sorted out for a jurisdictional area and then federate the pieces together? Or can there be one giant one?
I think we believe there's economies of scale in the technology underpinnings. We also believe at CRISP and CRISP Shared Services that a health data utility shouldn't necessarily be bound to the tech. It should be bound to the state as an asset and how they use that asset. And the underlying technology needs to be able to serve those nuances, so to speak, and how data is either aggregated together, how it's served up, to whom. So I think the health data utility is a combination of a tech infrastructure with disparate use cases and rules of the road at a regional jurisdictional level. And it may turn out to be, we may be wrong in the future. I think, everybody would like to say, let's have just one EHR and one HIE infrastructure. And that would be so much easier. How much of a reality that is, I don't know. So I think that we will see how that plays out. But I think it's really important at a state level or a jurisdictional level, there has to be one organization that's endorsed or shared endorsement and one underlying infrastructure, because if you're not doing that, you're not getting economies, and then your budgetary needs and the operational requirements become very much more difficult. So,
Angie,
you got anything you want to add to that?
No, I think all of that is really spot on. And we have to acknowledge that economies of scale is important, because that's a part and a piece of the success. And then also just making sure that we are seen as a neutral party, right? So as a convener of data, we are neutral to whatever the data insights or data intelligence tells us. We are neutral to, we're vendor agnostic. We are data agnostic, and this so that we can be Switzerland, right? We can say, yes, we want to help all these different stakeholders. We want to acknowledge and support all of the nuances and all of the requirements around data governance, because we can, and because you can trust us. And so I think all of those are really key components and keys for success.
Okay, great. So what I'm hearing is you might be able to tease apart the technical level, kind of like there's a cloud infrastructure and it's got reusability, you might actually be able to get some shared economies of scale by some back end services. But in either case, you still need to be highly tailored and have the ability to represent the specific needs of a jurisdictional or community, basically. So whether that's a state and state law or a lower unit of analysis like a county, you need to be able to really dial down the economies of scale and the standardization so that you can be a little more precise in meeting the specific needs of that jurisdictional boundary. So you kind of need both. But if you get your technology right, you probably can get even better cost performance and scalability. Did I say that back to you guys the right way?
Tim, I agree with that. But to add on to Angie's point, I think at a federal level, Angie, you mentioned this earlier, advocacy at the federal level could enforce some standards for data quality potentially. So you kind of want to go, bottom up, top down. Both approaches are important if you come at them from different types of angles, because there's so many new public health use cases. Like, during COVID, we thought about how many ICU beds are in utilization. HIEs weren't necessarily prepared with the data elements that they had at the time to say hospital X has 7 open beds right now, and to be able to respond to some states did it better, some HIEs did it better, but I think that there's two approaches here. Federally, we need to think about if any type of regulation goes into effect for interoperability beyond TEFCA and some of the new components. What data elements do we want, right? Instead of having to rethink this every time we go out and talk to any type of organization. So there's a lot to think about there. But I know health data utilities will go beyond, hey, can I see a clinical document for a patient? They're going to get to what's the emergency room wait time, or how many ICU beds, or what's the best way to implement an ACO from a cost perspective? Those are the new types of questions I think HDUs could potentially answer.
Just shifting gears a little bit. Beth Daigle presented sort of a technology roadmap for the state, and there were some common ingredients that I think align well with an HDU. What would you say are the sort of big fundamental table stakes? And I'll lead with one, which is sort of client matching or person matching. That seems to be kind of a basic building block you'd expect the HDU to have. What are some of the other basic building blocks that you really think that from that sort of standardized, even from the federal level on down, sort of driving to consistency and managing expectations, in addition to sort of basic client and person matching? What would be some of the other things that we might see common expectations for what the shared infrastructure for an HDU would be able to do?
Go ahead, Angie.
Well, I mean, I know we've said it already, but managing patient consent will continue to be table stakes. I mean, that's a huge impact and a huge factor, and something that HIEs are really good at. And we've cared a lot about for the past decade and a half. And so it's sort of been our business to do that. I think the other table stakes are health equity initiatives, and being able to convene health data with social data, and being able to support those initiatives around health equity to reduce those inequities, and focus on some quality stuff as well. So I think we need health data utilities to be as big as they can, to represent as large of data sets as possible, so that we get a regional perspective of data to provide comparative analysis at those local jurisdiction levels to support things like health equity and social determinants and things like that. So I think that's in some regards, some of the low-hanging fruit available.
Brandon, you got any more big ones that you want to add that you think will be foundational building blocks in that space?
I do. I have a couple extra ones, so obviously patient matching, the SDOH infrastructure components that Angie mentioned. A couple other ones that are really, really important that we have to get better at, I think, in the HDU space is relationships, understanding where, not just who the patient is and where they've been, but being able to say, this is the organization, this is who they have a relationship, this is what program they're in, being able to understand that. So a relationship management system. And I kind of combine that with relationship management and record locator. Those are two interesting technology components that need to be in place. I think more robust provider directories, not necessarily in how much better the tech gets, but ways that we capture that provider information needs to become more standard and universal as we think about that. And then I think one of the things that's very, very important is a notification service. A way to not just like have a practitioner or a public health person go in and take a look at what you have, being able to push and generate those types of alerts analytically, but push them and say, hey, there's something that you need to do. Almost think about replacing any type of notification service like the fax machine. You should be getting electronic alerts either built into your EHR systems or not. I think the last one is probably better interoperability services, whether you think about working with large EHR vendors or whether you really double down on new interoperability standards like FHIR to push data into the workflow of the practitioner in a clinical environment. I think that those are all geeky core pieces of infrastructure that we could talk about for a long time, but hopefully I kept it at a high enough level.
No, I think that's great. So we got client and patient matching, we got e-consent, we have this care mapping relationship tracking service, which, in the my instance, we call the active care relationship service. Mm-hmm. And then we've got basic notification services, as well as sort of a portfolio, if you will, of use cases that are implemented using FHIR or even more traditional mechanisms for moving it around. Did I miss any big ones that people should expect?
The only other one that I thought, and I noticed we have a couple of questions in the chat too, if you want to get to the, is emergency response and plugging into supply chain so that we can match resources where there is need based off of what the data intelligence tells us whenever we're doing those patient relationships type of activities.
Awesome. All right. Well, look, I do want to get us some time for questions. I can't see the questions, so if you want to read them, that would be fantastic. But they're certainly not showing up.
I'll read it out loud, Tim. The question from Dan Boyle: should health data utilities also support patient access as well as provider access?
Absolutely. I mean, I think that's where a lot of the e-consent comes. And I think a lot of the things we've seen, 21st Century Cures Act, the things you heard with citizen folks talk today, I think, when we talk about all of these, we're now taking for granted some of the things that happen relative to virtual care, telehealth, and consumer access to their own data.
I think health data utilities can aid Medicaid departments in some of the interoperability rules, specifically around patient access and API access to third-party vendors. I think this will become more and more common. I think I like to not just say perfect. I like to kind of say some of the hurdles I personally believe in. I don't know if our current connectivity is as good as some of the connectivity like a hospital EHR patient access could be. So we have to make sure that we're not over-promising data elements that might be better presented by the provider. I don't think HDUs are there. So I think those are some of the things that we might learn a lot of lessons from in the next year or two. But I do believe that patient access and their ease of capturing it and putting it into whatever workflows they want, HDUs can serve a critical role in that area.
I think that's a good point. Is one of the values of a health data utility and convening the data is to learn what the data tells us, right? We don't actually know what the data will tell us when we put all of the different pieces together. Exciting to want to know all of that, but I mean, we can certainly have certain hypotheses about what we think it would be or what we think it should say, but there's so much we have to learn. And then it's going to just say, okay, well then what about this and what about that? And that, to your point, Brandon, is going to be, are we collecting that data element or are we not? And do we have access to it? Is it in a different pot or from a different data source, or can we get it from the EHR or from claims or registries or patients or wherever? And so we still have that kind of evolution too, as part of, HDU 2.0.
Agree.
Awesome. I don't see the question. I actually am able to bring the questions up, so that's awesome. Thank you, whoever helped me there. But the other thing that I want to comment is, do either of you see, disaster management, FEMA kinds of situations, homeland kind of situations? Do either of you see the HDU as really being sort of the backup place for that sort of integrated record of maybe broader than healthcare? Where you can kind of go and have a reliable place to get back at that data should something unpleasant happen on a large scale. Is that something you see in the HDU portfolio?
I do see it at both a large scale FEMA type of an event level, but I also see it. I was just talking to a CMIO at a hospital system in Maryland. They had a ransomware attack about 12 months ago, and their primary out was the use of the health data utility in Maryland to say, I have patients in the room. I know that I've sent, I've integrated with this HDU, and access to that helped them get through some of the first couple of days of, hey, my systems are locked out, I have a ransomware attack. So I think if you take that very practical kind of a daily occurrence in the US around ransomware and extrapolate that out to a larger scale event, I think that a lot of effort and coordination needs to go in now so that organizations can use the health data utility in that event and know who to call. A lot of times we're very unprepared logistically around who do we grant access to, but I think that that's something that could be, not just at a state to state level, but at a federal level, we should have some policies and operational procedures to follow.
One last question. Given the quantity of data, do you see a role for artificial intelligence in HDUs?
Angie?
Yeah, eventually. It's, just like what the HIEs have experienced is you have to build trust amongst your membership and amongst your stakeholders and amongst all of your data sources. And so absolutely, I think that is a next generation, but we have to get there. And along the way, we have to be good stewards of the data. We have to be transparent. We have to be clear about what our direction and our objectives and our goals are and who can and who can't and for what purposes and all of that. And so long as we are diligent about putting all of those pieces in place, then AI definitely has a role in the future with whatever the regulatory parameters are or stakeholder parameters are. I think if we're going to be neutral, we have to just be neutral and incorporate those concepts as we engage, AI technology.
Brandon, you got anything to add to that?
I think we have to be a little bit careful, and it may be in HDU 1.0, Angie. Maybe we do enhancing data through artificial intelligence. I get leery about creating new data sets out of data, just from a regulatory perspective that comes with new requirements. If we're creating our own data out of, this person might, if we create a new diagnosis because we see lab results or something like that, I get a little leery of that. But absolutely, I think AI and algorithms to refine data utilization by a provider are really, really the next level. So we just have to be careful how we do it.
Yeah, I think it's all about trust, and it's about not overselling, the whiz bang stuff and foregoing some of the more practical everyday kinds of items. But well, look, I want to thank both of you, Brandon and Angie. Appreciate the discussion. We have put a nice sort of, capstone on the end of the day that I think was super packed. So thank you both very much. And we look forward to sort of seeing the evolution of HDUs over the next year. So I appreciate it. Thank you.
Thank you.
Thank you.
Bye-bye.